We're at the 7th Conference on Pathogenesis and Treatment and Prevention here in Kuala Lumpur. And we are here with Joel Gallant, who is transitioning from Johns Hopkins to Southwest United States.
Right.
And we're very appreciative to have you in the interim of that transition before you pick up the U-Haul and travel west. And we very much appreciate over the years the amount of good information we brought and updates that we brought from the conferences. I think you've been the most prolific in our presence. But most important now is probably this relevance of the clinical relevance of the guidelines to what does that mean and how that may impact the world.
So it was at this conference that the WHO announced their updated guidelines, which are primarily meant for resource-limited settings. And among other things, they have increased the CD4 threshold to 500, which is a major step. I mean, when you think about the fact that the vast majority of people in resource-limited settings who are diagnosed with HIV are diagnosed under 500, it essentially means treatment for virtually everyone.
Mm-hmm.
Now, one of the things that concerns me a little is that some of the other aspects of the guidelines changes have gotten a lot less press than the when to start question. Mm-hmm. And the guidelines specifically say that we should not be using stavudine or D4T, which may surprise people to know that it's still very widely used.
And that's the drug of availability.
Yeah, it's an inexpensive drug. There's lots of stockpiles. Countries are trying to use up those stockpiles. They also say that viral load monitoring should be a part of standard therapy, which it's certainly not in many parts of the world. So I'm completely in favor of early treatment, and I believe everybody with HIV should be on treatment. But I am a little concerned that we don't want to put the cart before the horse. That if we optimize the when to start question, we need to also be focusing on the quality of care that people are getting. And I think if most people, if they had a CD4 of 495 and were living in a country where they were going to get a D4T based regimen with no viral load monitoring, a CD4 every 6 months, possibility of stockouts interrupting their therapy, and no good second line options, they would say, I think I'll wait a while. And
truly, that might be suboptimal treatment.
Yeah. And so I do think that while I applaud the guidelines for moving in this direction, I really hope that we pay as much attention to the quality of the drugs and of the monitoring as we are to the CD4 threshold issue. I think that, clearly the guidelines, if fully implemented, will have an enormous impact on public health, and I think they would even, change the epidemic in terms of transmission. Mm-hmm. But we can't focus entirely on public health at the expense of individuals, and so if we have people with high CD4 counts developing neuropathy, lipoatrophy, lactic acidosis, extensive viral resistance without good second-line options, from an individual standpoint, you could argue that you've maybe done them more harm than good while helping to benefit public health. Mm-hmm. And this was an argument that was going on a lot in the U.S. when the DHHS guidelines and the IAS USA guidelines came out with a recommendation for treating everyone. People said, are we doing this for the public health benefit, ignoring what's good for the individual? But I think in the U.S. you can make a much stronger case. The drugs are safer. We have lots of options. We have good monitoring. So I don't see that as a big problem. But I think in terms of risk-benefit considerations in resource-limited settings, if you're going to treat somebody at an early stage of HIV where they're unlikely to die or develop serious complications, you better be doing it with reasonably safe therapy.
Because it seems as though when you start someone on treatment today, likely the treatments that they're on will be effective, and they're going to be on them for a very long time, unless something better comes along. Right. And I don't think you would suggest that we put them on 6 years of stavudine and TDI and then move them, because they'll be going through the same thing that I did, because that's the way the drugs evolved. But we learned since then that that's not, like you said, lactic acidosis was a large part of what we were dealing with back in those days.
And you do see this now. I mean, you go to places in Africa and places in Asia where stavudine is being used, and even to a lesser degree AZT, and you see new cases of lipoatrophy, which we don't see anymore. All of our lipoatrophy is leftover, but there it's occurring. People developing neuropathy, and of course, if your CD4 is 100 and it's a life-saving drug, but if your CD4 is 500, you may argue that it's not the best choice.
So the reason we're not talking about some of the drug research that's gone on, because most of it appears, the most exciting stuff appears as late breakers, and we are happen to be doing this video before the end of the conference. But what else did you take away from the conference in this event? We came across, and you will be seeing that before you leave. All of this. But actually, all of this is embargoed.
Right.
We've actually seen most of it in press conferences, but it's still embargoed. So we can't talk about it.
Well, I think there were two really great talks, not new data, but really good summary talks. And one was Steve Deek's talk at the opening session, and then Danny Dueck's talk this morning at one of the plenaries. And just kind of focusing on the issues of HIV as a chronic illness, that antiretroviral therapy really makes an enormous difference, obviously, in mortality and morbidity and quality of life, but that there is still something different. When you're on antiretroviral therapy and you're doing well, you still have a little more activation of your immune system, you have a little more inflammation. And no one expects these things to be a problem early on, but as Steve Deeks pointed out, that, as people get into their 50s and 60s and 70s with this sort of chronic revved up immune system and greater activation, we may begin to see differences. And, it was interesting. He's a clinician as well as a scientist, and said that the things that he spends his time in clinic talking to patients about are diet, exercise, keeping their blood pressure under control, keeping their blood sugar under control, keeping their lipids under control, talking about aspirin, talking about statins. That's what's taken the place of talking about drug resistance and antiretroviral drugs.
It's the comorbidity.
Right. And of course, everybody should talk about those things, whether they're HIV positive or not. But for people who are HIV positive, I think he makes the point that there may be an additional reason to be especially focused on that.
Stronger hit. I mean, that's what IFARA does, is now we're doing a lot of programs that are talking about all people living with chronic manageable disease, because the people living with chronic manageable diseases are hit by the same thing, and we also want to reduce the stigma of being in a group just because you're HIV. Yes, extra big hit, but it's important to include the population who everyone's dealing with these diseases and multiple co-diseases, in fact. So when do you leave for?
July 21st, get in the car, drive to Santa Fe, where I'll be directing HIV and hepatitis care and treatment at Southwest Care Center.
Will you start Ask the Doctor?
I have already revived that through a Tumblr blog. It's hivforum.tumblr.com, and I'm trying to bring back that old question and answer website that I used to have on the Hopkins site.
Are we hearing it first here, or is
maybe one of the So send in those questions.
So there is breaking news here after all. But no, this I should say. I hate to say, all joking aside, because it is fun.
Yeah.
And I think the one thing that we've learned is that video is really exciting, and stuff like you're doing is really answering questions for people that are really concerned about them. And some of them are funny, but I think at the same time we have a lot of folks who are dead serious about what they're dealing with, and they're doctors that maybe aren't ready to, maybe they don't even want to ask their doctor. So they're asking anonymously online, and that's always interesting to watch, I think, and to participate in. But we always thank you very much for being in our regimen of videos that we do.
It's always a pleasure.
And we welcome you to future ones, and we wish you well in the Southwest.
Thank you so much.
Thank you.
Good to talk to you, Chris.